Good morning to you all, and thank you for being out here. As Juanita said, I'm the cardiac electrophysiologist, which means I'm the rhythm specialist at Princeton. I had the privilege of being here 3 years ago talking about cardiac resuscitation techniques, and I thought when I was invited to come today, what would be of interest, to my audience. And I think I'd be remiss if I did not talk about atrial fibrillation. Okay, what should you all know about atrial fibrillation? As Juanita said, we commonly refer to atrial fibrillation as AF or AFib. It's easier, right? I have AFib, I have AF. What AFib is, it's an irregular and fast heartbeat that starts in the top chambers of the heart. And these top chambers we commonly refer to as the atria. So when you talk to a rhythm specialist, we will be talking about what's going on in the atria when you have atrial fibrillation. So in effect, atrial fibrillation, or AFib, is an electrical problem that disrupts the normal synchronized heartbeat. Okay? And as a result, it makes the heart a less efficient pump, because that's what the heart is, right? It pumps the blood around. And so when the electrical rhythm becomes disrupted, the normal electrical rhythm is disrupted and turns into a fib, the pump becomes less efficient. And so looking at these two pictures, let's focus first on the one right here on the left side. This is a representation of the normal heartbeat. Okay? So in all of us, when we're in rhythm, the electrical impulses start in this part of the chamber up here called the sinus node. Okay, that's where the electrical maestro is. And from there on, the electricity spreads in a very choreographed, very organized way to the rest of the heart. So as a result, if you were to feel your pulse and you're in rhythm, you will feel that it is very regular, nice and smooth, and it ranges between about 55 to 100 beats per minute. Okay? When you develop atrial fibrillation, what happens is you have abnormal impulses that you can see on the right side that start in the atria, in the upper chambers of the heart. These abnormal electrical impulses, they take over, they hijack the normal electrical circuitry of the heart, and as a result, the electricity becomes fast and irregular. And so if you were to feel your pulse and you have AFib, it's going to be racing and flip-flopping. It won't be going boom, 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 boom. It'll be doing boom, 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 boom. So if you look at these tracing at the bottom, you will see that when you're in normal rhythm, these spikes are nice and regular. Whereas when you're in a fib, the spikes start becoming erratic. They come at different times. Sometimes there's a lag between them. Sometimes they come very close to each other. And the average heart rate is above 100 beats per minute. Okay? So that's all nice, but why are we talking about AFib? Right? Why are we talking about this problem, not something else? Well, the reason why I bring it up is because atrial fibrillation is the most common rhythm abnormality we see in our clinic. So for example, on any given day in my clinic, 50% of the rhythm problems I encounter are in fact atrial fibrillation. And as it stands right now in the United States, there are about 5 million Americans affected by this disease. And this problem, unfortunately, is not going anywhere. It is in fact projected to increase substantially over the next 20, 30 years. So when you look at this graph, and I'm trying to keep these graphs to a minimum so we don't overwhelm you with a lot of data, but if you look at the year 2000, for example, as I said, the estimate was about 5 million patients with AFib. Projecting that into 2050, the number will be between 12 and 16 million. So this problem is increasing quite substantially. All right? Now, our part of the world is quite affected by this disease. This is data from the CDC. As you can see, the dark red representing more and more AFib. Alabama is covered in dark red. It's burgundy, right? We have a whole lot of AFib in our state. And that matches also the stroke rates. We are called here the stroke belt. We are part of the stroke belt. There's a lot of stroke in this part of the world, and there's a lot of AFib, and the two, to some extent, go hand in hand, and I will go over that in just a bit, the explanation, the reason why they relate to each other. So who is at risk for AFib? Are we all going to have AFib, or just a few of us? So once we hit, each one of us hits the age of 40, from the age of 40 onward, on average we have a 25% chance of developing AFib in our lifetime. So that's not uncommon. Now this is not to say that we all have the same risk, that's an average, right? So 25% of us over the age of 40 are going to have AFib, but some are going to be more than others. And so we try to determine, to look at risk factors. What's going to make it such that, you know, Mr. Smith is going to be at higher AFib risk than Mr. Jones, okay? So some of these risk factors we look at are, we call them non-modifiable, okay, which means I can't change them. So if you come to Dr. Hanna and you say, can you make my risk for having AFib lower, there are some things I can do, some things I can't do. For example, AFib is a disease that becomes more prevalent, more likely to happen with older age, okay? So if you're between the ages of 60 and 70, 5% chance of having AFib, whereas 15-20% of patients over the age of 80 will have atrial fibrillation. We can't change that, unfortunately, right? I wish I could. Males, 20% more likely than females to have atrial fibrillation, okay? And you know, white patients more likely than African Americans to have AFib. And obviously, if you do have a family history of AFib, meaning that if your parents, one or both of them, were diagnosed with AFib, especially before the age of 75, the chances of you having AFib is a little higher than the average person, okay? Now, luckily, there are also modifiable risk factors, which means there are things we can do to change your likelihood of developing atrial fibrillation. For example, we will emphasize weight control. Overweight or obesity puts you at risk for developing atrial fibrillation. If you have high blood pressure and you have diabetes, especially if they're not controlled, you're at high risk for having atrial fibrillation. We will advise you to stop smoking if you can, because there's a very strong relationship between lung disease and AFib. Think about it, you know, the heart is kind of hugged by the lungs, right? So if the lungs are in bad shape, the heart is going to, you know, feel that and want to go out of rhythm. Very important to avoid alcohol intake, okay? And, you know, especially in excess, but the more moderation, the better it is. And if you don't drink, it's even better, okay? We tell patients that, you know, from a plumbing perspective, you know, if you're looking at the health of your blood vessels, drinking a glass of red wine, you know, every so often is helpful. Unfortunately, with atrial fibrillation, there is no protective dose of alcohol. In other words, any drop counts against you. And, you know, if you have sleep apnea, which is, we're finding out that, you know, this is, you know, a fairly common diagnosis. If you do have sleep apnea, it is very important to get it treated, because patients who have untreated sleep apnea are much more likely to develop AFib than those who don't have it or have it and control it. So overall, the message is try to live as healthy as you can. Because if you protect your heart from every other respect, then you're protected from going into atrial fibrillation. How do you know if you have AFib? Okay. So in my practice, I see patients presenting with a lot of different symptoms. So not everybody has the same symptoms when they have atrial fibrillation. Not uncommonly, patients will complain about having palpitations. And palpitations are different in different patients. Sometimes people come in and say, well, I feel my heart skipping. Sometimes people come and say, I feel my heart racing in my chest and just stomping around. It's a sensation of butterflies. So when the heart is not beating in a regular manner, people feel it differently, but they feel it to be abnormal. And so once we hear a description of an abnormal heart rhythm, we're always trying to, you know, think about whether or not patients have atrial fibrillation. At times, patients cannot feel their heart racing at all. And what they present with is a sensation of pressure in the chest. You know, I'm feeling like I'm constricted. I can't breathe very easily. I'm dizzy. I'm tired. Okay? So these are symptoms that could be due to atrial fibrillation. Now, this being said, about a third of patients, so a good 30% of people who have AFib don't know they have it. Okay? And the way we find out is because they have an encounter with their healthcare provider. So say, for example, you have high blood pressure and you visit with your primary care physician on a routine basis. Then they will, you know, be listening to your chest and making sure, you know, they take your pulse and your blood pressure and everything else. And if they hear an irregular heartbeat or feel that your pulse is irregular, then you'll get an EKG that will tell us that you have atrial fibrillation. You may not be aware of it, but it may be there. So a third of the patients will come in without any symptoms, and we'll just find that accidentally, or as we say, incidentally. Okay? Unfortunately, a small category of patients with AFib will present with a catastrophic event. So the first time we know they have AFib is they come in with a stroke. Okay? Or they come in with heart failure. You know, heart failure means that the heart muscle is weak, and as a result, you know, patients are holding on to fluids, they swell up, they get really short of breath, they can't move around and do anything, and that may be the first time we find out that patients have atrial fibrillation. But as I said, generally speaking, there are some subtle signs preceding all of that, and we can pick up these signs if we listen carefully and be able to make the right diagnosis. Now, you know, I obviously don't want to scare you. I don't want to tell you that anytime you have some skipping or anytime you have some chest pressure or anytime you have some shortness of breath, you definitely have AFib. You know, by no stretch of the imagination am I trying to imply that. I want you guys to all go panicking and, you know, checking your pulses all the time. And so, but what I'm saying is it's important that when you feel there's something is gone awry, that it's not normal, that you get it checked. Because it's possible that some of the symptoms I described may ultimately prove to be the result of AFib. So how do we make the diagnosis? So you come to my office and you say, Dr. Hanna, I feel my heart skipping, racing, or I'm short of breath, etc. So one of the first things we will do is an EKG, very simple test. And so what we do with the EKG is we would hook you up to this machine right here and put, you know, a total of about 10 small electrical patches on the body, you know, 6 on the chest and 4 on the limbs. We connect it to the machine, and the machine will spit out a piece of paper, usually pink, that shows us the electrical activity in your heart. Okay? And you know, I'm showing 2 EKGs just to kind of give you an idea about what, you know, things would look like. The EKG on top shows you the normal heart electrical beat. And as you can see, you know, these spikes come in at regular intervals. They're nice and smooth. Whereas the bottom one shows atrial fibrillation. We can see the activity is very erratic. The spikes come in at irregular intervals. It's a little faster. So the EKG is a very easy diagnostic tool for us. You know, it takes about 5 minutes and we have an answer. Okay? Now, in patients who have symptoms that come and go, right? So if you come to Dr. Hanna's office and you say, Dr. Hanna, I feel my heart racing, but you know, I feel it once a week, it lasts for about 30 minutes or an hour, and you come to my office and you're not feeling, you know, these symptoms. I may do an EKG and find that it's normal. It doesn't mean that when you have the symptoms of the racing or what have you, you're not in AFib. So how do I find out if you have AFib? What we would do in situations like this is we would provide you with a monitor you can wear at home. And it would look something like this, where you have 3 patches you put on your chest, you hook them up to the wires, and as you can tell, he's wearing that monitor on his belt, but sometimes they come where you put them around your neck. And these monitors record the electrical activity in your heart, either in a continuous manner, or they, you know, detect abnormal events, you know, either too fast, too slow, or irregular. And once these machines pick up these events, they get transmitted to us, and we look at them, and we can tell based on what's, you know, the recordings, based on the strips, you know, whether or not you have atrial fibrillation. In rare instances, or I should say less common instances, if patients have AFib that's very infrequent, or we think they may have AFib, and we're trying to determine whether it is the case or not, but the symptoms are infrequent. You have them once every 2 months. Okay? What we would do is we don't have a monitor you can wear easily for that period of time. So what we would do is insert a little monitor that looks almost like the flash drive that's sitting right there plugged into that laptop on the side. You know, you see it, you plug it into your computer on the side, and it's like a memory stick, essentially. These are very, very small. You can see them here. And in fact, we inject them under the skin. They come on the equivalent of a little syringe with a plunger, and we just push them under the skin. And these will monitor your heart rate for 2 years, 2 to 3 years continuously. Okay? And they transmit to us from your home. So we can tell, based on these monitors, whether in fact you do or don't have atrial fibrillation. So as you can tell, our ability to make the diagnosis has improved astronomically. You know, we have a lot of tools to make sure that we know whether or not you have atrial fibrillation. And that is because this is a relatively serious rhythm problem. We don't want to miss it. Okay? Now, is AFib dangerous? AFib, generally speaking, is not imminently dangerous. Meaning that if you're at home and you go into AFib, you're not going to have any catastrophic event happen right there and then immediately. You know, there are other rhythm problems that when they happen, right as they happen, you're at risk. AFib is not one of them. Okay? This being said, AFib is not a benign disease. Okay? AFib we take very seriously. Why? Because AFib increases your risk of having stroke 5 times. Okay? It puts you at risk for having congestive heart failure. It increases that risk 3-fold. Okay? It has been linked to a higher risk of dementia. And it overall can increase mortality 2-fold, especially in patients who have underlying heart disease. Okay? So let's talk a little bit about AFib-related strokes, because strokes are catastrophic. You know, when you lose part of your brain, it's a problem. Yeah? And so as we know it, stroke is the number 3 killer in the United States. And in total, AFib is responsible for 1 out of every 5 strokes. To put it in another way, 30% of patients who have AFib will have a stroke. So what do we have to do? We have to prevent that. Okay, why? Because strokes from AFib produce more disability than strokes from other reasons. So if you have a blockage in your carotid or you're in the back of your vertebral artery in the back of the neck, these can produce strokes, but strokes from AFib usually lead to more disability because you get a bigger showering of clots, if you will, and they're likely to come back. You know, so people who have one event are likely to have another one unless we do something about it. So the clots in AFib that ultimately make their way up to the brain start in the left upper chamber of the heart, called the left atrium. Remember, I told you the upper chamber is called the atrium. So the clots in AFib start in the left atrium. Why? Because when you have AFib, the blood pools. The heart is not squeezing that blood out from the chamber. Okay, so it pools. It sits there, and as it sits there, it just starts clotting. If you draw a sample of blood from your vein and you put it on a countertop and you wait long enough, it will clot. Same thing, because it's sitting, it's not circulating, it's not being pumped. So with AFib, that blood will stagnate in the upper chamber, and as it stagnates and it's not circulating, it will form a clot. And ultimately, a piece of that clot can break off, okay? And when it breaks off, it finds its way through the aorta, which is that big blood vessel right here that comes out of the heart. And this aorta supplies, obviously, all our organs, right, with arterial blood. And so one of the places this fragment of clot can go is to the brain. When it goes to the brain, as you see on the right side, it can cause ischemia, which means there is no supply of blood or oxygen to that part of the brain. And that part of the brain dies, and it forms a stroke, okay? So it's important to be familiar with some of the signs of stroke. If the face droops, if the speech becomes slurred, if there's a part of the body you can't move, that's serious. And time is money. Time is brain tissue. Okay? So once somebody has these types of symptoms, we don't sit around and wait for them to go away on their own. We call 911, because if we can get to that patient early enough, we can bust the clot or do other things that may be able to allow the patient to recover some of that brain tissue that has been rendered ischemic and may ultimately lead to a stroke. Okay? So we want to avoid having a stroke in the first place. Nobody wants a stroke. We don't want our AFib patients to have a stroke. So what we normally would do to prevent strokes as best as we can, we thin the blood out. We give blood thinners. Why? Because that way, when the blood is stagnating, right, it's less likely to clot. It's thin. It doesn't want to clot anymore. And so you guys all heard of aspirin and Plavix. Some of you folks may be on these medications. Well, aspirin and Plavix are very good for the plumbing of the heart, but they're not very good to protect you from having stroke if you have AFib. So when we talk about blood thinners with AFib, we are really not talking about these medications. We're not talking about aspirin and Plavix. We're talking about warfarin, okay, or Coumadin. For a long, long time, this was the only medication we had to treat atrial fibrillation, to prevent strokes in atrial fibrillation. The problem with this medication is, obviously, it was very, very effective, but the problem with it was that it's hard to take because the medication interacts with your diet. If you eat salads, it becomes a problem. You have to have it checked because the levels go up and down. It can interact with other medications. So if somebody gives you an antibiotic and you're on Coumadin, it will mess up your levels. And you can start taking the Coumadin today. It may take a week before it starts working because the levels may not get there fast enough. Luckily, now we have newer drugs. We have new blood thinners that most of us are prescribing now. You know, we kind of shy away from Coumadin, except in certain circumstances, obviously, where Coumadin has to be used. But for the most part, when somebody has not been on a blood thinner and we're just making a diagnosis of AFib and we want to start them on a blood thinner, we would use one of the new agents. And you may have heard ads on TV. They're, you know, very aggressive advertising to the public. You know, Xarelto, Eliquis, Pradaxa, all these, you know, Ceveza. These are all brand names of medications that are blood thinners. The good news about those is that you take them, they start working very quickly. Within a couple of hours of taking the medication is already working and your blood is thin. Very important as well, they don't interact with your diet as much. So you're free to eat most of what you want to eat. And you don't need to check your levels. There are no levels to be checked. You just take the dose and that's it, period. Okay, so you can avoid the blood draws. And, you know, aside from them being very effective, they also seem to carry a little bit less risk of serious bleeding than warfarin does. Okay, so their profile is very favorable. Now, everybody who has a fib does not have the same risk of having stroke. Okay, so that's getting into the weeds here a little bit. You don't have to, you know, remember that in details, but I just wanted to throw it out there so you understand that, you know, you may encounter a friend of yours who has a fib and is not on a blood thinner, yet you're on a blood thinner. It doesn't mean their doctor doesn't know what they're doing. It means that maybe the risk of having a stroke is lower than yours, so they're not on a blood thinner and you are, because we're always weighing the risk and benefit of everything we do. I don't want to give you a blood thinner that gives you some risk of bleeding without justifying it, without you having some risk of having a stroke to justify you being on the medication. And so your physician will typically use this calculator here. So we compute a score. It's called the CHADS-VASc score. It kind of sounds like an electrophysiologist came up with it. And so what we do is we look at whether you have congestive heart failure, hypertension, what your age is, you have diabetes, have you had a stroke, do you have, you know, blockages in your arteries, you know, are you a male or a female? And each one of those risk factors gets a score, you know, either 1 or 2. And we add up how many of those you have. And the score, the CHADS-VASc score could be 0. I mean, if you don't have any of these, 0, it means your risk is very low. So generally speaking, a younger individual, say in their 55 or 58, who otherwise are healthy and have AFib, may not be on a blood thinner. Okay? On the other hand, if your score is 2 or above, unless there's a reason not to, in other words, if you're not bleeding or having you know, something puts you at risk of bleeding, we will put you on a blood thinner. We'll prescribe a blood thinner. Okay? So this score is very, very useful in our field because it gives us an idea, an ability to kind of sort of predict who would get benefit from the medication and who wouldn't. Okay? So what happens if you cannot take a blood thinner? Let's say your score is 3 or 4 or 5, right? So we know you have some risk of having a stroke, but yet you can't take the blood thinner for a variety of reasons. Either, you know, we have patients who fall, right? They're unsteady, and we're worried that if they fall and they're on a blood thinner, they can get hurt. We have people who have polyps or diverticulosis or AVMs, you know, vascular malformations in the colon. People can bleed. So sometimes we are kind of stuck between the rock and the hard place, right? You know, we want to give the blood thinner because we're worried about patients having stroke, but we can't give it because there's a risk of bleeding. And so luckily there's an alternative, okay? The alternative is called the Watchman device, and that's what I'm showing you right there in the screen. It's really a plug, and I'm going to try to explain to you what the logic behind it is. Remember I said that when you have atrial fibrillation, you have a stroke because blood clots start in the left upper chamber of the heart, right? That's called the left atrium. Well, to kind of hone in on this a little bit, the left atrium, which is right there up here, that's the left upper chamber of the heart, has a little projection out of it right here. It's like a finger extension out of the left atrium. It's called the left atrial appendage. It's called the appendage. It kind of reminds me of the appendix. Okay, it's the appendage. And so 90% or so of blood clots in AFib patients, when they start in the upper chamber, they start in that area called the appendage. So what we would do with that Watchman device is we would go in, access into the left atrium, go to the appendage, and put that plug. You see that white plug up here? That's the Watchman device. That way, if there's a blood clot in that appendage, it's trapped. It can't make its way past that plug. And that way, you are protected. Okay? So this is an image of, this is a patient we did a while back. I'm going to see if that video will work. Here we go. So we put a tube, you see this big tube that runs through the vein in the groin, and then we get into the upper chamber of the heart where the tip of that tube is. It's in the appendage now. And we take an image, we inject some contrast to see what this appendage looks like. And you kind of see it flash through the screen. You see how it opacifies, and you see it up here. That's what the appendage would look like. So we localize it, we see what it looks like, we make measurements to determine what size plug we need to put in. Once we have taken that image, we've determined the right size plug we need to use, then we move to the next step, and we will, in effect, deploy the plug. And on X-ray, you only see the shadow of the plug, but you can see it up here kind of faintly. It looks like a strawberry. Okay? So that plug now is situated in that appendage, at the orifice of that appendage, such that it is preventing blood clots that may ultimately form in that appendage from migrating through and going to the brain and causing stroke. Okay? So after we implant this device, as I said, called the Watchman device, we typically would give patients blood thinners for a short period of time. Once the heart has healed over the device and the device is scarred in place, then we put patients on aspirin, and that's all they need. You need the full dose aspirin for the rest of your life, and you are protected as well as you would with Coumadin. Okay? So that's a nice alternative that's available now at Princeton that we are providing our patients. So we've talked about how to prevent strokes in AFib. We've talked about blood thinners. We've talked about the Watchman implant. But how do we deal with the AFib itself? Okay, what do we do when you come in with AFib? Do we keep you in AFib? Do we try to put you back in rhythm? And so there are really two big strategies, two avenues of treatment. The first one is to do what we call rate control, which means the patient comes in, they're in atrial fibrillation. We look at a lot of other things, you know, what's your heart health, how much symptoms, how many, you know, what are your symptoms, etc. And in some patients, we will say, let's not worry about trying to get you back in rhythm. Let's just try to worry about controlling how fast your heart rate goes. And so we will use simple medications, beta blocker, calcium blockers. These are oral pills that you take that lower the heart rate. So you're in AFib. Yes, your heart will be irregular when you feel it, but it's not racing. It's not going 100, 120, 150 beats a minute. And that sometimes is enough for patients to live a normal, healthy life. In other instances, we decide that the best course of action is to actually put the patients back in rhythm. That's called rhythm control. Okay? And so in this instance, we would use specialized medications called anti-arrhythmic drugs, anti-arrhythmia medication. And in combination with a cardiac shock, sometimes an electrical shock, we put the patients back in rhythm. And the medication, this anti-arrhythmic medication, helps us keep the patient in rhythm. So you're in normal rhythm, but you're on some medications to control it, okay, to keep you there. So how do we decide? It's not an easy decision-making process, you know, to describe, you know, over lunch today, and so that's where you develop that relationship with your physician, and you trust, you know, their judgment about what they want to do. But it typically takes into account your symptoms. Do you have symptoms or not in AFib? What is your heart rate doing? Do you have any other cardiac conditions? Do you have valve problems? Do you have a leaky valve? Do you have a tight valve? What is the likelihood that if we try to put you back in rhythm that you will stay in rhythm? Because we don't want to do a procedure on you or give you medications that ultimately we know are going to fail. There's no point in doing so. What is your overall level of functioning? Are you affected by being in AFib, or are you living an okay life without any problems, and maybe we shouldn't do anything? And ultimately, obviously, we talk to our patients and we make sure that we explain to them what we can do, what the odds of success and failure are, and listen to their opinion. You know, what do you like your physician to do on your behalf? Okay? So it's a complex decision-making process, and we spend quite a bit of time in the clinic with each patient discussing what the best course of action is. Now, a question I often commonly get asked is, can you cure atrial fibrillation? Can you cure it? Can you get rid of atrial fibrillation? There really is one way to do it, and it's to do a procedure called an ablation. Okay, and we've been performing AFib ablations at Princeton since we started the program 12 years ago, and we've done large number of those. And what the procedure entails is us threading catheters through the veins in the groin, going inside the heart, again going to where the left upper chamber, the left atrium, because that's where a fib starts most of the time. So we go to the left atrium. We try to find these abnormal electrical impulses I mentioned to you earlier in my presentation. We try to find them and cauterize them. Okay? Most of the time, these electrical impulses cluster around the veins that drain the lungs. We all have veins coming from the lungs that drain into the upper chamber. They're called the pulmonary veins. So what we do is we measure the electricity around these veins, and that's usually where the problem lies, and we go ahead and cauterize it. We make these encircling lesions. You see, this is a view from the back. See, this set of pink dots are lesions that we've put around the veins going to the front to get rid of this abnormal electricity. Now, it's important to be realistic, right? I need to be realistic with my patients. I need to tell them what to expect. Can I cure everybody that has AFib by doing a procedure? The answer is no. We cannot cure 100% of patients who have atrial fibrillation by doing an ablation procedure. Now, there are a lot of other rhythms where the success is 95, 99%. AFib, the success rate ranges from 70 to 85%. Okay? And we typically like to do this procedure, if we have to do it, on patients who come in early in the course of their disease. So AFib, without being too technical, AFib comes in two different flavors. Okay? One of them is referred to as paroxysmal atrial fibrillation. What that means is your AFib comes and goes on its own. It lasts only a couple of hours, maybe a day or two, and then quits on its own, goes back into normal rhythm on its own. That's a good variety of AFib. That's the one that has the higher success rate with the ablation. When your AFib progresses, if you wait too long and your AFib comes and stays, and you have to be shocked to be put back in rhythm, then the success of the procedure comes down. And so just like most other diseases that you can think of, early is better than late. Treating it early is better than treating it late. Okay? Now, treating AFib literally is, in the full sense of the word, a collaborative effort. It's an effort between you and your physician. You cannot just rely on the physician to cure it and not do your part. And what I mean by that, it is important to adhere to good advice. Lose the weight. Treat your sleep apnea. Control your blood pressure. Don't drink. Don't smoke. So all of these, if you don't address them, you can come and have a procedure done and do very well for 2, 3, 4 years, but then if you don't follow this advice, the AFib will come in a different shape and form, and we go back to square zero and have to start treating it again. Okay? So in conclusion, AFib is very common. It is important to recognize it because AFib is not a benign rhythm problem. It's important to seek expert advice when you have atrial fibrillation. And the good news is that there are a lot of options to treat it. And so these options are available to you. Just make sure you knock at our door, and we're happy to help. Well, in conclusion, I'm very glad to have had the opportunity to be here. I want to thank Debbie and Juanita and everybody else involved in organizing it. Thank you very much for your attention. I am happy to take any questions that you may have.